notice that I ain't going nowhere. I ain't blowing no smoke. I mean, I've been sober, but you should've known it. I wasn't going.
Alright, so hello guys, welcome back to another video. Welcome back to my channel. It's your RN Steph. So in this video guys, it will be different from the others that I have. So in this video I'll be going in more into nursing side of things with like a knowledge-based aspect. So this video will be focusing on sepsis, right? So sepsis is a medical emergency, and the outcome of the patient depends largely on how you react, um, how promptly the treatments are given, and all the interventions that are done if they are done in a timely manner. So first of all, we'll get a definition of sepsis. So sepsis is a serious condition in which the body responds improperly to an infection, right? So persons, when they present, they will tell you that, oh, my partner has been unwell for 3 days with a cough, right? Bringing up green phlegm or yellow phlegm or gray, and they are present with UTI symptoms for a few days, or something that trigger an infection, right? Because if it begins with the chest, it could be a chest sepsis, or urine infection can lead to urosepsis, right? But whichever way, it is an emergency, and the body is forced to fight this infection, which may result in what is called a septic shock. And in a septic shock, we have a dramatic drop in blood pressure. We realize that the other organs, the lungs, the kidneys, the liver, they become pressured, and because due to the lack of blood pressure reaching these organs, they eventually what you call shut down. So it results in multi-organ failure, and that is where the person is no longer able to come back from the sepsis. But like I said, all this it depends on how quickly we respond to suspecting sepsis. So what causes sepsis? So sepsis could be caused from bacterial infection. It could be from some parasite, fungal, or any infection, either viral as well, but they all lead to sepsis. So it starts from some infection that leads to sepsis, right? So what are some of the signs and symptoms that persons normally experience in early stages of sepsis? So persons will complain that they have been going hot and cold for a few days, so they have been having a temperature. Persons may complain that they were having chills, they were shaking, and they have rapid breathing, and that their heart has been pounding, so fast heart rate, right? So those are some of the signs and symptoms persons may tell you. They may even tell you that when you ask them. So it's important in history collection as well to ask about certain things. Ask them how, if they have been passing urine for the past few days. They might tell you that, oh, I've not been passing much urine, so that's reduced urine output, and that's further down in sepsis as well. So in sepsis, the temperature is not always high. the temperature can be low as well, and that is what you call a cold sepsis. So the temperature doesn't have to be high. And you'll find that persons, when the temperature is, they come with temperatures like 33, 34, 32 sometimes, and you have to warm them up to get an optimum temperature, because with sepsis it can result in, like I said before, the organs shutting down. So, there's not much perfusion in terms of blood pressure wise to the organs, and of course, circulatory wise, the patient would be cold, right? So we warm them up. You can use the in UK we have a warming blanket we call the bear hugger, or we can use the fluid warmer. You give them some warm fluids, right? Um, so when they present in A&E, when we notice that, like I said before, the temperature, either it is too low or it is high, right? And their breathing is either rapid or labored. Yeah. Neurologically, persons, they're confused, disoriented, or there's a change in mental status, and that's one of the early signs of sepsis as well. That's one of the red flags. The relatives may, when they come with patient, they'll provide history telling us that patient over the past few days they have noticed confusion, and patient is normally Jesus 15 oriented and stuff. So new onset of confusion is one of the red flags of sepsis. All right. Skin changes may be pale, mottled, bluish skin tone. Yes, that's also one of the signs of sepsis. Also, persons may be generally malaise, a feeling of extreme illness and fatigue. They may tell you that, oh, I've been so tired over the past few days and I can't do nothing much. And the relative who may ring the ambulance, they may tell you that over the past few days, they noticed that their relative has been sleeping more, and so all of those little signs they are good for the history, and that all lead to the diagnosis of sepsis. So, like I said, some of the red flags of sepsis are new onset confusion, high or low temperature, and a fast heart rate, and rapid labored breathing. Okay, so in UK we have what is called sepsis 6, and it's very important that we start the sepsis 6 as soon as we suspect a person of having sepsis, especially when they're using eye, right? So if you suspect sepsis, um, the factors that would prompt screening for sepsis would include a news stool has been triggered, um, the relative or carer is concerned, they may have some recent chemotherapy or a recent risk of neutropenia, and that one is very, you have to, within the first hour you have to start treatment, especially when it's risk of neutropenia or some recent chemotherapy. If the patient looks unwell, evidence of organ dysfunction, and yes. So treatment wise now, treatment wise, first of all, you escalate to a clinician your concerns. Um, the clinicians, they do listen to us, and if we as nurses come to a clinician and say, doctor, so and so is not looking so well, they're using 8, and you know So, and then clinician will say, okay, I'll come and see this patient now. Well, I don't know about other trusts, but at my trust, the doctors are very good. And if nurses, we work together as a team, nurses and doctors. So um, if we bring a concern to the doctor, they'll come and assess the patient and prescribe some treatments. And sometimes once they see the news pop up on the screen, they'll assign their name to the patient and come to that patient immediately as priority. So when we're suspecting sepsis, we up the priority, so we put that patient as a priority 2 so that they could be seen quicker. So yes, you inform a clinician, you give oxygen if required. So you start oxygen if the saturation is less than 92%. We're aiming for saturations of at least 94 to 98%, especially if they have no other breathing issues in the past. We still maintain normal saturation. So you give oxygen. So by the times we have to start with non-rebreathe of 15 liters because the saturations is very low. So we start with non-rebreathe sometimes and then we titrate down accordingly. Um, but like I said, if the person have other breathing issues, like for example COPD and stuff, and their target is 88, 92, and they're at risk for hypercapnia, so we aim for 88 to 92%, and that's of course per doctor's orders. If doctor says 88 to 92%, we just don't assume it's 88, 92%. But at the same time, we don't want to over oxygenate the patient because that can make it worse if they are retainer. All right. So we would send bloods, and in your blood set we would include blood cultures, VBG, and the VBG would include blood glucose. It would include lactate, FBCs, UNEs, LFTs, CRPs, and the clotting. So in extreme cases, a lumbar puncture would be indicated if we are considering a pathogen or we need to find out what pathogen it is, but I haven't seen any cases like that so far, right? So in terms of treatment, we give antibiotics, IV antibiotics, and we normally give maximum dose broad spectrum therapy, right? So the broad spectrum would be one of the best antibiotic to fight the source of infection because we need to get on top of it quickly. So immediately as the antibiotic is prescribed, sometimes we don't even wait until it's prescribed. They give the verbal order, give so and so. Once you confirm there's no allergy to such, you give antibiotic immediately. Like I said, the survival of the patient with sepsis depends on how quickly we give treatment and how quickly we respond. Persons can actually survive when they have sepsis. Um, Sometimes they come in, they look so unwell, and then we think like, oh, I don't think this one is going to. But you're surprised after you start giving the little treatment, the they give the IV fluids, and that's the next one I'm coming to. After fluid resuscitation, you're surprised. You see them take time coming around, and they look much better than when they just can't come in and their news would go down. Right. So like I said, we give IV fluids. So we give a bolus of fluids over 15 minutes if the lactate is over 2, or if the systolic blood pressure is less than 90 millimeters mercury, right? And we repeat the blood pressure. If there is no improvement after a second bolus, then we have to get a senior clinician on board and more discussion as to what, right? Sometimes these patients may end up on CCU or HDU for some vasopressors or something to keep. to get the blood pressure up, because sometimes after a lot of fluid resuscitation, the blood pressure still hasn't picked up, and they need CCU for the monitoring. All right. So, like I said, the survival of the patient depends on how quickly we respond. Right. So you immediately, as a person come in and you suspect sepsis and they look unwell, right? Clinician on board, observations, bloods, start treatment immediately, antibiotic fluids, yeah. And then it leads to other things you can do, like catheterizing the patients, because you need to monitor the intake and output, because with the massive fluid resuscitation, we need to monitor how much fluid is going in and how much is coming out if the kidneys are, doing their job. All right. So we use the news tool, and for those who don't know what is a news tool, it's a scoring system that we use to determine if a patient is deteriorating in terms of vitals. So each of the vital signs will be given a score, and based on how high the new score is, you can tell if patient is improving or not. So in my case, this patient would probably be scoring about 11, right? So I'll give you a little scenario. For example, I will use 40-year-old. 40-year-old, let's say Pat, as the family have been concerned over the past few days. Pat has been having a cough, has been wrapping up at home, feeling hot and cold, and the family today noticed that she's become more short of breath, and Pat is complaining that her heart is pounding out of her chest, and so on. So they bring her to A&E. Right. So when Pat arrived now, triage nurse, well, we would take Pat into resus based on the scores and stuff that the ambulance crew told us. So, right. So this is our pretend patient, Pat, 40 years old. First of all, Pat is very young, 40 years old. So, yeah, Pat is for full escalation, because past medical wise, normally fit and well. So, Pat for full escalation. So we act urgently. So immediately as Pat come into A&E, we take some bloods. We immediately obtain a blood gas. Based on blood gas, lactate of 4. All right. So we realize that pH 7.28. Okay, then Pat is acidic, lactate is high, so Pat is looking very unwell. We get an X-ray ordered. X-ray confirmed by doctor showing pneumonia, right? So temperature is 32, blood pressure is 85/60, and heart rate is 123, and respiratory rate is 28, and Pat is becoming confused. So right there, so now Pat is scoring Pat is scoring 3 for respiration. Let us calculate. 3 for respiration. Pat is scoring 3 for temperature. BP scoring 3. Temperature for heart rate, Pat is scoring 3 again. And for neurological status, Pat is newly confused. So that's another 3. Which one did I leave out? So you have temperature, pulse, respiration, blood pressure. Right. So Pat is scoring 3, 6, 9, 15 on the news chart, and Pat is only 40 years old. And Pat is normally fit and well, no past comorbidity. So you know that Pat is for full escalation, right? So immediately now we do bloods already, right? So doctor say, all right, Pat, no allergies confirmed. Give her some Coamox, and we might have to give something else, probably some Tazocin, one of the, or some gentamicin, it depends, but something broad and vigorous. So yeah, immediately we start give the treatment antibiotic. We give some fluids. We start with a bolus and we keep doing it. We catheterize Pat from little after we start the treatments, because right there and then we know that Pat is not looking well and she needs vigorous treatment, right? So guys, like I said, and afterwards you can repeat the blood gas as well to see if Pat is improving, and if there's no improvement in her observations, and we keep repeating those observations at least every 30 minutes based on the new score, right? So yes, so like I said, the survival of patients with sepsis depends on how quickly we respond to an incoming patient with sepsis. So we can't delay giving antibiotic, we can't delay giving fluids, we can't delay blood taking, and we can't delay escalation. So we need to start the treatment within the hour. This clock starts the moment the patient arrives and we suspect sepsis, the clock starts there, right? It's very important, right? And sepsis is probably one of the leading causes of deaths, right? But like I said, the successful for the patient to survive, it depends on the healthcare, the healthcare professionals, how quickly they respond to a patient with sepsis. So guys, thank you so much for watching my video. And if you have any questions, you can leave them in the comment section down below. Leave a thumbs up, share my video, and any questions, like I said, you can ask in the comment section. And thank you so much for watching my video. See you in next video.
Take me